Mouse.
Okay, so as a 25-year-old female, gradually declining vision for about 2 years. Her father also had poor vision. No past medical history. She takes Nexplanon implant for medications. She has 20/80 in the right eye, 20/63 in the left. IOP was 18 in both. That's the first image.
Looks like a color fundus photo of the right eye, kind of zoomed in. The trace is clear, nerve, there's pink sharp flat. There is a little bit of pigmentation at the nerve border inferiorly. My attention is drawn to the macula. I see an area of what appears to be like subretinal depigmentation, possibly.
He's pointing to inferior. You have to. They can't see.
The inferior, yeah, the inferior arcade. There, yes, and maybe some along those vessels, maybe dot blots or a little bit of dilation of those vessels.
Okay.
Maze there.
I'm gonna help you out a little bit. Point you to the nerve. Do you notice anything about like the color of the nerve?
Maybe a little bit of nasal, sorry, temporal pallor, maybe.
Mm-hmm. Yeah, just and also for the finding you had here, just wanted to remind you she's 25 years old too, so that's helpful. And then this next image.
Vitreous clear nerve has a similar temporal pallor.
Yep. I think this was just artifact.
Yeah, on the macula there, yeah. Okay. OCT image. The fovea appears normal. The architecture appears normal. Maybe a little bit of actually disruption of the architecture, maybe in the
That's pretty good. It's pretty normal. You can come back.
Pretty normal.
Once you show later slides, you can come back to that one because there is something there. It's super subtle.
What do you want me to go back to? Sorry.
Oh no! Later, come back to this one. This one looks pretty normal, but there's something there. But it's
hard I didn't want to. Yeah. Gotcha. Mm-hmm.
OCT scan.
So left eye.
Left eye. Attention is drawn to the where the optic nerve enters. It does maybe appears a little elevated.
It's supposed to be.
Okay.
Yeah. I think for me, when I was looking at this, trying to find something with it, obviously knowing the diagnosis is a little bit easier, but if you were to cover, because this, you can notice the OCT, usually we're not showing, this far out nasally, right? On both of the OCTs. But if you were to cover the nerve, how would you normally find which eye is the eye you're looking at in OCT?
RNFL gets thicker.
Mm-hmm. Do you see the RNFL getting thicker on either of these?
No.
Yeah, I think that was. Is that the abnormality you were talking about, Dr. Cohen?
Yeah, very nice. Yeah.
OCT of the optic nerve head, and we see a thickness map. There is this right eye. We see significant thinning, especially temporally and infratemporally. Kind of correlating with where we see that pallor in the previous color fundus photo.
Yep.
Left eye OCT nerve. We see thinning again in the temporal region, including the superior temporal and the inferior temporal region. Pretty significant thinning. And again, correlating with the area of pallor we see on the fundus photo.
And when I see this on the nerve, because the nerve scans are sometimes goofy. Sometimes the nerve's small, sometimes it's shifted, sometimes the vessels are shifted. Sometimes, they call it red. Well, like red on there's some word for it in the glaucoma conference, like too much red. But sometimes the red's not abnormal. That's why I like to go back to those line scans. If there's central vision loss and from the optic nerve, typically on the line scan, you'll see the RNFL kind of missing or substantially thin. As you go through the raster scan, it's supposed to thin out a little bit in the center because you don't have those peripapillary, nerve fibers going north and south, but it shouldn't be as thin as it is in this patient. So I think that's a real cause of vision loss in her.
Yeah. And then for differential, I'll just go back to the first one. So again, 25-year-old female, gradually declining vision, family history of that as well. And then the findings, of course, with the temporal nerve thinning. So what is
going
your
back to that
differential?
color, so that color spot he was looking at in the right eye, you mentioned how young the patient was. So that's just a reflection.
Oh, thanks, yeah.
So that's it. When you look at young eyes, you'll get these reflections. You can see it kind of goes along the vessel. It could be a PAM lesion or something, but it's just a reflection off the young fundus. It is probably, it actually might be a little funny looking because of the absence of nerve fiber layer toward the center of the macula, and that maybe that one spot's got a little more nerve fiber layer, so it's a little more shiny. You can look for nerve fiber layer defects on your color photos. It's hard to see them on this one, I think, just because the nerve's kind of not very good.
Yeah,
All right,
and you can see like in inferior and superior, you can kind of see the nerve fiber layer there. But yeah, it's kind of difficult to tell without a red free filter or like infrared whether there's some missing fiber layer there.
All right, go ahead. Sorry.
So do you want to come up with a quick differential for us?
Maybe glaucoma, optic disc drusen,
Yeah, those are some good.
autosomal dominant optic atrophy.
Yep. There you go. Autosomal dominant optic atrophy, any sort of hereditary optic neuropathy, demyelination, a whole bunch of them there. But yeah, you kind of hit the nail on the head with that one. So further history, turns out her father was also adopted. So they were seen at University of Iowa in 2007. They were diagnosed with autosomal dominant optic atrophy, and the mother and brother don't have any vision problems. So genetic testing was ordered, and you can see here the OPA1 gene mutation, as well as the USH1G gene mutation, and then this collagen 2A1 gene mutation as well. And this is kind of like the differential for what these mutations may cause. But OPA1, I'll talk about the OPA1 gene. I don't think I'm really going to discuss the USH1G gene, but this one's common in Usher syndrome, which has the issue with deafness, of course, and retinitis pigmentosa like symptoms. So this is autosomal dominant optic atrophy. That's the most common hereditary optic neuropathy. It's also known as CHAIR, if I'm saying that right, optic neuropathy or type 1 optic atrophy. It is autosomal dominant, but has variable penetrance, presenting in both sexes equally. The prevalence is 1 to 12,000 to 1 to 50,000, depending on the sources. There's the highest prevalence in Denmark due to the founder effect. Pathology-wise, it is a mitochondriopathy associated with mutations in the nuclear OPA1 gene on chromosome 3, Q28 to Q29. It encodes for a mitochondrial dynamin-related GTPase, which is involved in mitochondrial membrane stability and biogenesis. Its dysfunction leads to impaired oxidative phosphorylation, which increases reactive oxygen species in retinal ganglion cell and leads to retinal ganglion cell apoptosis. Another related disease is Behr disease, or autosomal recessive optic atrophy. It's a little bit more aggressive than the autosomal dominant variant. It's also associated with these OPA1 mutations. Some of the signs and symptoms, it's usually with the autosomal dominant variant, you're going to have the insidious onset of bilateral vision loss, usually starting within the first decade of life. And as a general rule, I mean, I don't think it's a hard, fast rule, but you're going to be losing about a line of Snellen visual acuity every decade. 80% end up better, though, than 2200. In terms of family history, it may be absent due to the incomplete penetrance. And as you can see, the mother and the son did not have any issue with their eyes, but just the father and the daughter. Color vision deficits are common, usually tretinopia. And then you have this focal wedge-shaped temporal optic atrophy, or it can be diffuse as well. And this is just some pictures of that. And then also just the temporal RNFL thinness. And this is due to apoptosis typically affecting the papillomacular bundle. Patients may also present with central, secocentral, and paracentral scotomas, as well as a diminished visual evoked potential and diminished ERG N95 on the electroretinogram, pattern electroretinogram. Some of the associations, 20% may be associated with deafness, cerebellar ataxia, peripheral neuropathy, myopathy, and chronic progressive external ophthalmoplegia. Usually these, I guess, syndromic variants are termed autosomal dominant optic atrophy plus disease. There is also an autosomal dominant OPA3 gene mutation that may result in autosomal dominant optic atrophy, which also is combined with cataracts and deafness in the first decade of life. And there's also another autosomal recessive variant of the OPA3 mutation called costive optic atrophy, and it results in early onset optic atrophy and later onset neurologic disorders such as ataxia and cognitive deficits, and as well as you might find urinary 3-methylglutaconic acid in the testing. I don't know if I've ever seen or heard of anyone ordering that, but I guess if you're an ocular geneticist, you might. Workup wise, you can order, the usual stuff: visual acuity, dilated fundus exam, get a visual field, color vision. Of course, the Ishihara plate isn't going to pick up the tretinopia, so you're going to have to get the Hardy-Rand-Rittler plate or Farnsworth D15 or D100 plates. Optic nerve studies such as an RNFL are useful. MRI to rule out intracranial pathology is good because could be an intracranial mass causing an issue there, or like compressing the nerve tracts. Genetic testing for OPA1 is often of limited value because there's such a large number of causative mutations. If it happens to be positive, such as this case, it's pretty diagnostic. But otherwise, if it's negative, it doesn't necessarily mean you don't have autosomal dominant optic atrophy. You obviously want to rule out other hereditary optic neuropathies such as Leber's and Wolfram, otherwise known as DID mode, which is diabetes insipidus, diabetes mellitus, optic atrophy. I forgot the D actually. Anyone want to chime in? Is it deafness?
Probably deafness. Yeah, I'm not sure.
Yeah, it's probably deafness. But yeah, and obviously, if you are worried about the autosomal dominant optic atrophy because of the syndromic associations of with deafness, you definitely want to, be following them with a hearing test. Some of the management, again, no established treatments, just annual exams. You want to check their extraocular motility, just to make sure it's not CPO associated, and then obviously hearing evaluation. There's a couple treatments that have been described. Idebenone is one, which is just a short chain synthetic analog of CoQ10. It's more hydrophilic and can more easily cross the blood-brain barrier. It's 300 milligram TID by mouth, promotes mitochondrial ATP production, enables the bypass of certain parts of the electron transport chain, and just limits the production of reactive oxygen species. There's some possible visual recovery, especially if it started before the first year of progression, which you're probably not going to catch it at that time anyway, because these patients usually present pretty far on because it's such a slow, insidious onset. So the treatment utility is pretty low. The same type of treatment is used in Leber's, but it's kind of a exercise in futility. It's not really much else you can do. There's some antioxidants and other supplements, B12, C, and lutein, that have been proposed using a similar mechanism. There's also some anecdotal evidence of a possible neuroprotective effect of brimonidine, but as has been discussed with prior lectures, that research was kind of flawed. They just had like a petri dish and doused it in brimonidine versus latanoprost and noticed the ganglion cells died less with brimonidine, but I don't think that's very indicative of the actual environment of the eye. And then finally, there's some therapies in the works, intravitreal gene therapies using adenovirus delivery mechanisms of ND4. And then also I was reading about a way they can reprogram induced pluripotent stem cells into retinal ganglion cells, and they're trying to transplant that. But again, very much early in development. I don't think we're going to see it for quite a while there. That's about it.
No, that was very nicely done.